kind of the same concept as immunoembolization, is the older treatment for this disease of getting a catheter, a little plastic tube, out under X-ray guidance out into the arteries in the liver, and injecting chemotherapy followed by a substance to, or in conjunction with a substance, to block off the blood flow to the tumors to try to cause the tumors to die. An additional approach to that, using a newer product, is drug-eluting beads. So imagine, again, the concept of tiny, tiny beads which are permanent in the artery that you marinate in chemotherapy and then inject them into those same arteries going to the liver, and then the chemotherapy leaches off those beads, most of it in a couple hours, but some in a continued degrading fashion. Time release, yeah, that's what I'm looking for. Fashion, again, and the point is, there have been elegant studies there was a very elegant study almost 20 years ago, and let me just go through the concept of it because this is important to this. It looked at if you give, adriamycin is a type of chemotherapy agent, okay? If you give adriamycin through a vein and go throughout the body, what's the concentration of the adriamycin in the blood? Okay, that's group 1. And I haven't thought about this article in a long time, so if I misquote it, please don't think I'm an idiot. I'm trying to get the concept across, okay? So group 2 was if you take a catheter and put it in the arteries going to the liver and infuse the adriamycin, what is the concentration in the blood? And I forget if they were looking at the blood draining from the liver or not. Again, I haven't thought about this article in a while. Maybe the concentration was twice as high when you did that. And then if you mix the adriamycin in an oily substance, a thiazole, and added gel foam, and you did the same injection into the liver, the concentration was 5 or 10 times higher, something like that. So the point is, the ability to get a much higher concentration of the chemo at the liver tumors. And I have the reference for that article somewhere in my office, but that's the basis of this concept. Okay? Photomustine infusion is a chemotherapy agent. It is not available in the United States. It's shown some promise in Europe. We treated a few patients with it more than 10 years ago, and some marginal responses. It's not something we've done any time recently. Now let's talk about what's IHP and PHP. IHP is isolated hepatic perfusion. Okay, for one moment, I'm going to take off my coat because this is a small room and it's getting a little hot up here.
And you're working hard.
A lot of gesticulations, I guess. Okay, let me try to draw this out. And this is why Grant kindly provided Sharpies. Okay, because...
There you
go. If the projector goes off, will it come back on quickly? Or just put some...
There you go. Never mind.
Remember my comment about I'm lucky I can make slides. Okay. Let's try to discuss isolated hepatic perfusion first. Okay, so if this is the liver, and we have the heart lives up here, there's a huge vein, the inferior vena cava. Oh, okay.
Very good. Thank you.
Okay. Whoa. Sorry. I think it's back on. Okay. And then Obviously, there are arteries going to other things. Okay. So the goal is you want to try to infuse a very, very, very high dose of a chemotherapeutic agent. In this case, the drug is called melphalan, into the liver, but you can't let it get out into the body because it's so incredibly toxic at the doses being given. So what they do is, so this is major open abdominal surgical procedure, okay? And we don't do this at Jefferson. We have sent a couple of patients where we felt it was appropriate to a guy named Jim Pingpank in Pittsburgh, okay? And I should say that I sent Jim an email 6 weeks ago saying, I'm going to be talking here. If you have some slides you want to send me or some data or that kind of thing. I didn't hear back from him. I did hear back from him about some other things. I didn't get any specific information. But, I mean, I do want to discuss this because this is a procedure which is available in the United States right now. So, open up belly. Have to temporarily occlude the main vein that's bringing back all the blood from the legs into the heart. And it picks up blood from the kidneys and the liver and a whole bunch of other organs. So that has to be tied off. And then they put a catheter, again, a plastic tube in here. And they put another tube in this artery going to the liver. And then you need another bypass because you got to get the venous blood back to the heart. Okay, now let's go through this. So, this is clamped off. And now the blood draining out from the liver can go out through this tube. Okay? And put the high dose of chemotherapy in here. It's actually warmed because if it's warmer, it's more apt to kill better. So you infuse the high dose in there. It percolates through the liver. Then the liver normally has veins which drain into the inferior vena cava. But now the only place the blood can go is out this tube. So it goes through a filter system. Kind of sort of like dialysis, but I mean it's not dialysis, okay? But it goes through a filter system and then it goes back into the bloodstream. Okay? So the whole point is you're infusing incredibly high dose of melphalan, goes through the liver, sucking it back out in this isolated segment, putting it through a filter to get the chemotherapy out of there, and then dump the blood back in. Sort of, kind of, in a very simplistic nature. Again, this is a major surgical procedure. I'm not a surgeon, okay? But this is kind of sort of what they do, okay? There's a couple percent mortality of the procedure, meaning, I mean, admittedly, a couple percent is not high unless you're that couple percent. It's a 7 or 8 hour operation, a week to a week and a half in the hospital, a couple days in an intensive care unit. It's not curative. They haven't shown that it improves survival. They haven't shown that it, while it may have a higher initial response rate, meaning that if you get an MRI a month or two down the road, the tumors look smaller, but that hasn't impacted survival, and it's a lot to go through. The other thing is, after patients have had this, we really can't do the kind of arterial-based treatments immunoembolization, radioactive microspheres, chemoembolization, because of two reasons. Number one, the arteries really get burned up. The arteries get irregular and blocked and that sort of thing, so we can't effectively do the treatments we typically offer. And number two, patients often, as a side effect, there's a high rate of bone marrow suppression, meaning red blood cells are down, platelets are down, which also limits our ability to perform subsequent procedures. So, that being said, this is a therapy that is available now in the United States for this disease, and some patients choose to go for it. And as I say, often many of the people we see have self-selected, saying, whoa, that's a little bit much for me. But that's trying to be an answer to his question about what IHP is. PHP, percutaneous hepatic perfusion. Go with the same concept, only you can get rid of some of the big surgery. And I didn't list all the things they do, because tiny arteries under the liver, they have to tie them off, and the portal vein is the reason, is another inflow of blood, which they clamp off during that. So this is a really, really, really major abdominal surgery. And I lost my train of thought. PHP is, there's a device which let me explain it, then I'll show a picture. Okay? Yeah. A catheter with two balloons on it. So I'm running out of colors. Well, here. So rather than having to go in and temporarily clamp or tie off the inferior vena cava, there's a big balloon up here and a big balloon down here that blocks the inferior vena cava and a tube going through. And that allows the blood to suck out. And if someone can turn that on, and oops, sorry, and excuse me one moment, end slideshow. Oops. It's right here. And then here are the balloons. Here's the main vein draining the liver. And you can see sort of the same system of what I was describing from the older operative technique in a percutaneous technique, which this can be performed more than once and patients don't get as sick. This product is approved in Europe. It is not approved currently in the United States. The application has been in front of the FDA for more than a year, and there are ongoing issues which the company is dealing with the FDA, and there's apt to be some representatives of that company in the audience. I don't want to get in trouble. I don't know. You can find them and pin them down. Yes, ma'am.
When you say percutaneous, what that says to me is that you don't have to cut open the abdomen. Am I right?
Yes.
Thank you.
Sure. And percutaneous means doing something through the skin, as opposed to open under direct visualization. There was a question up here in the front, then we'll go to the lady in the back.
I'm taking a time out.
Oh, okay. I give those. Next, please.
Are there any of these therapies that can be given if somebody only has one kidney?
Yes, as long as kidney function remains good. I mean, remember, most people can live on one kidney. Okay? If the kidney function is too compromised, it makes us concerned about repeated arteriography, meaning putting these little catheters in the arteries, injecting contrast, taking x-ray pictures, which is required to do because we've got to make sure we're injecting the stuff at the right place. But as long as the kidney functions fine, yes, there was a question up front, and then the gentleman in stripes. I'm sorry, I should have, the question was, does it matter if you have only one kidney?
You were talking about all the different therapies. Since you mentioned FDA, are the other therapies approved by the FDA?
FDA doesn't generally approve procedures, if I'm not mistaken. They approve devices, they approve the stuff you use for the procedures, they approve devices, they approve drugs. To the best of my knowledge, I don't think FDA approves how to take your appendix out or how to take your gallbladder out. To answer your question, immunoembolization, we've done phase 1 and phase 2 trials on the road to that. It's a very, very long road. Immunoembolization is not approved. None of the chemotherapy drugs are indicated for use in metastatic ocular melanoma because no one would spend the money to get a drug approved for such a rare disease. Isolated hepatic perfusion, again, melphalan is a 40-year-old, 50-year-old chemotherapy agent. That's not approved for ocular melanoma. The issue here is there's a device that needs to be used. And one of the holdups is the effects of the melphalan.
One more.
Yes.
Do you happen to know if in Atlanta, Georgia, at Emory, are there any interventional radiologists that can do those procedures that you talked about, those therapies? Are you talking to any of those, or do you know?
Let me go back to the prior question, and then I'll answer this one. Okay. The other thing is surspheres. We're currently doing a study which may help them go down the long road to get FDA approval for metastatic uveal melanoma. There are 2 radioactive microsphere products in the country. One is called TheraSpheres. It's approved for hepatocellular carcinoma. The other is called Surspheres. It's approved for metastatic colorectal cancer. People are using Surspheres for breast and neuroendocrine and metastatic uveal melanoma and other indications, but it's only approved for colorectal cancer. The other question is, okay, Emory has interventional radiologists. Do I regularly talk to them? No. I mean, that's something you'd have to address with them. The other thing is, look, I'm an interventional radiologist, but notice who I'm standing here with, a medical oncologist who, we have endless emails and phone calls going between us all day long. We work very closely together. This is not an isolated, Carin and I just go and do procedures. That's not the way we work. Okay? Gentlemen in the stripes.
What about for tumors outside the liver? Multiple organs.
Okay. The question is, what about the extrahepatic sites, meaning tumors outside of the liver? And the answer goes back to, number one of those earlier slides, that in most patients, not all patients, in most patients, longevity is determined by control of the disease in the liver. Tumors outside the liver tend, though not an absolute, to be slower growing, and they tend, not an absolute, to not cause problems. Now, yes, there are occasional patients who get a tumor in the brain and it may be radiated. There are patients with lung tumors who may have various therapies, and there are some other things which Takami is looking into for systemic approaches, which we'll probably be discussing tomorrow. But in general, the focus is on the liver. Okay? Yes, ma'am.
I just want you to clarify, I want to see if I got this right, that if it starts in the liver, that's fatal, primarily, most of the time. But if it's somewhere else, that's not necessarily an issue. It's the liver that's the issue. Is that what you said?
It's the liver that's the issue, but I guess the hypothetical question she's asking is, how often do you see someone with metastases elsewhere in the body but nothing in the liver yet? And I'd have to say that's pretty rare.
Correct. The liver primary cytometastasis is maybe 80%.
Okay, so if it is somewhere, it started in the liver, and then
That's
it's...
right.
Okay.
And then at end of the battle, more than 90% of patients has liver tumor. And 10% patients develop the metastasis outside the liver first. So this may be, some kind of genetics is really different, but these patients tend to live much longer. In general, liver, in the previous studies, say probably 6 months to 1 year in average. And lung metastasis, who have lung-only metastasis, their survival is 2.5 years, 2.6 years. So that's published from Kettering. So therefore, that means outside the liver may be slow, and outside liver is probably not so important as the liver. And brain metastasis is common in skin melanoma, maybe 30%, but uveal melanoma patient, we don't see that frequently, especially from the beginning. We don't see that. Therefore, we don't do the brain MRI on a regular basis, and this patient has some symptom, or on this patient has very good response everywhere, and then we'll just make sure nothing happens. So as of today, we are looking for a cure, but cure is big with far. As of today, we are doing our best to keep the disease quiet. So by combining many concepts, and eventually, hopefully within 5 years or before I die, I will see the cure, but we have to work together.
Gentleman in the blue shirt had a question.
You said IHP was approved in this country. Does that imply that generally private health insurance covers it?
Excuse me. I didn't say IHP was approved. I said IHP was available. Again, surgical procedures generally don't require FDA approval. And
Well, it's available. Is it generally covered by?
in that I don't do it, I haven't had to try to get insurance approval for it. I can tell you that the 2 patients recently in the past 6 months who we've sent to Jim Pingpank have both readily gotten insurance approval for it.
That's my, if this is such a big to-do, and such a big operation, why would you even, and it doesn't have a better outcome, why would you go there? Why would you have this done?
I'm going to tell you something.
Okay.
Okay?
Why go through all of it, I guess?
The Wall Street Journal manages to find space for 1 cartoon a day. And back in my single days, through the 80s and 90s, the 1 or 2 a month that were really funny, I'd clip out. So imagine the guy standing up at the lectern and looking out over the audience. And the caption to and the caption is, "That's a very good question. Next question, please." They followed the same drawing a couple months later with, "That's such a good question, I don't want to spoil it with a lousy answer." That's a reasonable, that's a reasonable question. And the published data from like a series from I think 2003, 2005, a review article from Alexander in 2010 is still kind of talking about 1-year survivals. And you're asking a very reasonable question. Next question, please.
A very small fraction of patients have a long-term survival.
Yeah, there was somebody on the website that was 9 years out.
Yeah.
So therefore, but how frequent? Maybe based on the figures that they're showing, maybe 5% or less. So, and majority of patients, unfortunately, have a very good initial response. Eventually, we have to understand that tumor is coming back. In other words, this is most aggressive chemotherapy. Just give a 1 high dose and kill everything. So if that happens, that's good. However, probably 5% of tumor cells are alive after that. Eventually, that can back grow, and then next time we can't do any other treatment because of hormone toxicity. So, but I have to admit that this is, one of the treatment which show the relatively long-term survival in small number of patients. So, for example, for young patients, they will go.
Okay, we're going to take questions 1, 2, and then there were a couple over here. And just because there was a 5-second lull in the questions, I started putting up some pictures, but the main focus here is I dragged myself down here to just stand in a forum like this and answer questions. Sir?
Metastatic liver ever been treated by a transplant with a healthy liver?
Totally reasonable question, which is, why can't I get a transplant? Okay, couple answers for that. And as I said to Takami as we were waiting for the train, I bet a lot of the discussion this afternoon is going to be the kind of conversations we have with patients routinely in our Monday afternoon clinic. The answer is no for several reasons. Number one, unfortunately, with the rapid progression of the disease, you got to wait a long time to get a liver transplant. I mean, patients are on liver transplant lists for years. And with this tumor, you don't have years to wait doing nothing, number one. Number two, it's not indicated. They don't do liver transplants for metastatic disease. Okay, so how the hell did Steve Jobs get a liver? Well, he had a there's a bit of that too, I'm sure. But, okay, he didn't have pancreatic adenocarcinoma, which is the horrible pancreatic cancer that lots of people die from. He had a neuroendocrine tumor, which is a slow-growing, it is a malignancy, but it's an incredibly benign-acting malignancy in many patients, and there are some centers that will transplant for neuroendocrine mets. I'm not sure if it's on study or what exactly the deal is. The other thing is, after you get a liver transplant, you get immunosuppressive drugs. And, because you need immunosuppressive drugs so your body doesn't reject the liver. So, just imagine, the whole thing we're trying to do with immunoembolization is boost the immune system to try to fight this thing. And imagine wiping out the immune system. It's just, the disease is going to ravage. That's why. Sir?
The previous slide that you had, that there's a non-approved therapy, is that of this, I've forgotten what it's called. PHP. Does that have the same effectiveness as the more radical surgery?
They've only published an abstract so far, and that's a reasonable question to ask the company representatives if they are able to answer that, which they may not be able to answer it because it's currently before FDA approval. Look, I'm not a lawyer, I don't know from this stuff. The response rate is about 8 months, and it's my understanding that survival is about the same, but that it's not as morbid a procedure up front. Okay. There were some questions over here. Yes, ma'am.
So, what if your situation, every time it's spread, liver or wherever else, you've been able to remove it surgically? So there's no evidence of disease. There's no tumor, and we're so tumor obsessed with cancer treatment in this country. It's insane. Where are these areas? I've heard it sort of thrown around in the online communities. Well, the tumor cells are seated in the bloodstream. It's like mold in the blood, and it's just going to keep popping up. Are you still a cancer patient if the tumor's been cut out? What does it mean to be net?
Okay, so the question is, if you have no evidence of disease, if you have no imaging that shows you have tumor, are you still a cancer patient?
You've had you've had the liver resection, you've had it cut out in other places in the body, so there's no tumors present. But is it just the nature of this disease? Where is the cancer? If you keep cutting out these tumors, but they keep coming back, where is the cancer?
Buried somewhere at a cellular level that your body is successfully suppressing till the next time it pops up. Does that? But I'm going to. Okay. But that's definitely begs a shared question.
I was given another answer, and that is that we don't currently have machinery, MRI, CAT scans, that can actually tell you at the millimeter level what you have percolating in your body.
Well, I mean, that's why I specifically said cellular level. We can't look at cells throughout the body. I mean, the resolution of a PET scan is about a centimeter, so anything smaller than a centimeter isn't going to show up on a PET scan. And MRIs can detect small tumors in the liver, I mean, less than a centimeter, but not 1 or 2 cells. And now, going back to the shared answer.
So,
No.
Probably two more questions.
Well,
if they're quick.
I'm okay for a little bit. Someone wants to get a cab. That's okay. Renee would like you to speak a little louder.
So gentle. Speak up.
See what we have to deal with?
Terminology is clinically undetectable.
Okay.
So that means if you have a cancer, you have like a 10 to 12 million cells. If you have all tumor cut out, still you have a 10 to 9 cells in the body. It is 1 billion cells. Cancer cells are still in the body.
We can't hear you, sir.
Cancer cells are still in the
body.
body.
We'd love to hear you, but we can't.
Yeah.
Sorry.
So even though nobody can detect anything, cancer cell is still in the body. Okay. So cancer cell, that's the reason why chemotherapy tries to decrease the number from the 1 million to 0. So generally speaking, that is not going to happen for the eye melanoma, especially because chemotherapy resistant. But I think your body immune system is fighting. So therefore, even though 1 billion cells, still most of patients survive. You know, so therefore, immune system is important, and at the same time, the modality to, cut the tumor cell number down dramatically, such as surgery or some radiation or chemotherapy, is additional. But still, cancer cells are in the body. Okay, some probably balance of the immune system and the cancer cell behavior. Some tumor is very dormant, eliminated by immune system. So that is a major concern for the transplant surgeon. So I got the call from the doctor from Michigan saying that this patient has primary eye melanoma with end-stage liver disease. So and then family insists, patient insists, I need a new liver because I have to survive. And then doctor said no, because if you remove your immune system, it's a different story. Even though 900% survival rate, if you remove immune system, nobody ever say it's 100%. Therefore, immune system is important. At the same time, major approach which debug the cancer is very important. So therefore, ideally, we have to combine these two approaches in the future. Unless somebody has like a miracle chemotherapy medicine, that's not going to happen. That's the reason for the limitation of the liver perfusion, because it's high dose chemotherapy. Keep giving it, it's okay, but eventually liver is damaged, and then liver cannot survive through. So therefore, okay for this palliation, but it's not good for the cure. So that we have to think about.
I have another question. What about when you have, say, if you had a...
So I have to tell you, your immune system is strong enough to fight it. Okay? Don't be upset and scared, okay?
If you have a rather large 2 centimeter and maybe a 1.5 centimeter, then you have some other smaller, millimeter size tumors. Would you go in with the SERPs or the whatever that interventional?
Okay, so the question is, if someone has pretty limited disease, how do we approach that? And while the purpose, I can't stand up here and give out personal advice, and there are a lot of other considerations. By the same token, if someone walks in to see us and they have limited disease less than 50% of their liver replaced with tumor, and they're otherwise okay and totally functional and feeling great, and the kidney function is normal, and the liver function is not severely compromised, and blah, 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 and a whole bunch of other things. And if it's not appropriate for resection, cutting out, which we said most people are not, and there's no interest or appropriateness for isolated hepatic perfusion, which, as I said, most people who walk through our door have self-selected, no way on that, then one, we have a clinical trial for patients with radioactive microspheres, which we are currently enrolling patients in. And in some patients, we also consider immunoembolization, which is the therapy we've been doing for more than a decade at Jefferson. If someone shows up with a lot of tumor, more than 50% of the liver replaced with tumor, then we're looking more at things like chemoembolization or the drug-eluting beads or those sorts of things. We have seen that radioactive microspheres don't work well if someone has a lot of tumor. Okay? We know that immunoembolization doesn't work well if you have a lot of tumor. You need something stronger. You need chemo in there. Also, in addition to the embolization, which is blocking off the blood flow to the tumors. There was Tim?
So we keep talking about the immune system, all right? And obviously that and...
I hear this question going straight to Takami.
I know. and Dr. Sato, you pushed it really hard, immune system. Why don't we work harder on the immune system then?
Sure. The question is, why don't we do something else to boost the immune system? Or I guess the question is...
And I'm talking naturally too. I'm not talking I'm not talking drugs. I mean, just, things that we know work today.
What can be done to boost the immune system?
So answer is difficult. Okay, and then issue is if you hire 10 times more policemen in Washington D.C., they cannot recognize the bad guys. Just they are on the street. So how we can just make the the immune system specifically against cancer cell? That's a kind of major challenge. So, and then if I say so, you might go into the internet and buy a supplement. So that's not so bad, but it's not going to work well because it's not specific, and there's no study to prove anything about eye melanoma. So eventually, we do need a specific active immunotherapy like cancer vaccine. But cancer vaccine itself may be weak. Cancer vaccine, like a vaccine. So these days, there's so-called anti-CTLA-4 antibody. Eventually, immunotherapy itself takes 2 hours of lecture, But there are many ways to boost up the immune system, but it has to be specific. So how we can make it specific? We should just use a cancer antigen, for example, cancer cell to immunize patient. We have to use a special mechanism that to attack the cancer cell by using a specific mechanism that cancer used to suppress the immune system. Like ipilimumab, you have a Yervoy is one of the interesting medicine. Again, that is not specific, but it's very important to reverse immune suppression. So now PD-1 antibody is coming. So that is also the very specific mechanism that cancer cells suppress the immune system. So by using that, eventually in combination with specific cancer antigen, cancer vaccine, we might be able to boost up the immune system better. And then, since we don't have any cancer vaccine, myself and Kevin Sullivan, developed the in situ cancer vaccine approach. We use a cancer cell in the liver to kill it and then boost up the immune system at the same time. But it's still not perfect, but we may have to add some different reagent. We may have to combine this with Yervoy or anti-PD-1. Actually, I'm submit some kind of proposal to combine this immunotherapy, immunoembolization in Yervoy. So we have to just walk through the process to be more efficient,
But we do agree that boosting the immune system to the ultimate degree through whatever means we can do is the best. Not the best, but is a good way to fight this. I won't say the best, but...
Yeah, but again, as I told you, we need some dynamite or bomb to kill it dramatically. like cutting out, give a chemotherapy, some, new medicine like a MEK inhibitor, cure it. But eventually, we might have to develop the memory of immune system. Immune system are down to 10 cells. If immune system down recognized, may grow back. So therefore, we do need to develop the immune memory. That's a kind of major challenge. And then on the other hand, we are educating natural for other cells to just directly kill the cancer, like target snipers. Not educating them, just release it to the cancer cell. We are doing same simultaneously, but the best way is just educate immune system in combination with decreasing volume. So that's a way to go. But unfortunately, I don't have a Nobel Prize. Hopefully.
But the natural killer cell project is something that Takami is working on aggressively in his lab, and hopefully is something that will be available in the hopefully in the near future.
Yesterday.
No, not yesterday. Question up front, please.
Okay, so if you haven't had metastasis yet, is there a way to prevent against it? I mean, I know the signals and stuff, but is there and getting frequent MRIs and CAT scans to keep a good look on it, but is there anything else?
So
the question is how to prevent metastases if you don't have them yet.
Adjuvant therapies.
Yes.
As of today, official answer to your question is nothing. Okay. So that's official statement. Therefore, the more very accurate, sensitive testing is important because we have many approaches, and there are several new clinical trials, and therefore, once we find it, we have a way to attack. Even though it's a wrong way to find a cure, but still much better. So the people who need something, we talk about some adjuvant experiment approach, and then probably in the near future there is probably 2 potential clinical trials. Again, I can't give you too much hope because the far away to go. The one is the as Dr. Herbert found that the BAC1 involvement of class 1, class 2. So they have been saying that so-called histone deacetylated inhibitor, that is not the strong killer though. It's a modulator of the abnormality. So therefore, we are not going to see the regulator like total disappearance of cancer, but it's kind of slowing down. So by slowing down the cancer progression, make it behave better. So may allow your immune system to prevent the spread. So the medicine is so-called the HDAC inhibitor. That might be in the clinical trial sometime in a couple of years. But I cannot say when. You have to wait because it's a long way. And one of the medicine probably very famous in the website is valproic acid.
Valproic acid. An old anti-seizure medicine.
Yeah, that medicine is a classical and weak histone deacetylated inhibitor. And I have to tell you, if I use that for the patient with cancer in the body, it's very weak. We only see the slowdown effect. We don't see any regulation. But if the theory is right, and if we use it in early stage, it's very non-toxic medicine. So maybe. Again, we don't know. We have to do some clinical trial to do it. The other medicine that we are doing at Jefferson is based on the clinical trial for the stage 4 patients. That's the sunitinib. That's a quite different mechanism. HDAC inhibitor is the reversal of the class 1, class 2 to class 1. And then sunitinib Sutent is a blockade of the receptor for the signal like growth. And then sunitinib also has potentiation effect. Sunitinib has anti-angiogenic effect. So we only talk about that because we know that medicines stop the growth of the cancer patients in 2,000 patients. Therefore, we have some evidence that medicine may work. But again, this is highly experimental. So therefore, we would just sit down at least 30 minutes and talk about this, and then if patient will try it, we have to mutually understand that this is experimental. Nobody ever show any, proven accuracy. So, but still, we will do this case by case. And then I can't tell anything right now, but we are going to present the preliminary result of this slit limb adjuvant trial in this year at ASCO meeting. And I cannot give you too much promise, but we'll see.
We didn't hear that the last 2 years.
You don't need to hear.
It's being presented, and you're not allowed to pre-release data. That gets you kicked out of the ability. Okay. Oh, I'm sorry. No, I was going to say, I don't know if someone else clicked that or if while I was writing it clicked. This is an arteriogram. This is the liver. This is a patient with a couple of big tumors. And this is when he came back 2 months later after immunoembolization. And what you see is dense contrast staining, a lot of blood flow to the tumor in very irregular vessels. And here you don't see them. This is just a later phase, same patient, again, before treatment. And when he comes back, just a little bit of residual vascularity. And that's the kind of angiographic finding we see. Again, I didn't mean to jump to that, but once it was up there, I didn't want to offer some explanation. And at the risk of being rude, I'm going to try to catch a train in about 35 minutes. But, Grant, thank you for having us. Thank you so much for inviting us.
I know this has probably just kicked off even more questions you have. Dr. Sato is going to be with us tomorrow. We'll also all be going over to dinner right now, but join me again thanking David for coming down.
It's really our pleasure to be here. I mean, obviously there are some familiar faces in the audience, and it's our pleasure to try to be helpful and that sort of thing.
Thank you.
Sure, but for me, this is definitely interesting to go see all the PhD stuff. It's something my father had many years ago, and the advances are intriguing. But with that, I know we dove very quickly into the medical side of things. I encourage all of you, though, we'll head over to dinner right now. We have a reservation at Carmine's, which is 2 blocks right to the right of the hotel, and then 2 blocks down 7th Street. So let's head down there. But I encourage you to think. Yes, we're here for the medicine. Yes, we're here to learn from the experts. But we're also here to recognize that we're not alone in this battle. That is why we're calling this the I'm Not Alone conference. You're here to meet each other, to lean on each other, to learn from each other. The energy and the learning you'll get from the OM community, I think, is staggering. So look to the people to your right and to your left. Reach out, say hello, and enjoy dinner. Thanks.
I think it's very nice what he just said.
Is it workable?
Thank you so much. Okay, take care.
Are we leaving right now?
Big questions?
It's in my car.
Okay.